Well, good afternoon, everyone, and welcome to this afternoon's webinar session on improvement and system working. I'm Miriam Deakin, the Director of Policy and Strategy at NHS Providers, and I'll be chairing this afternoon's session for you. So just to give you a little bit of background to the programme and to the aims of today's session before I introduce our expert panel and before we kick off. As some of you might know, this is the third event in a new NHS Providers programme on how trust-wide approaches to improvement led by the board in particular, and that's our specific focus, the role of the board, can help in this next phase of pandemic recovery and beyond. And it's great to have such a fantastic audience here today. We've got a real range of expertise out there in the audience as well as in our expert panel. So we've got NEDs, chairs, chief execs, directors of improvement, medical and nursing directors, got a real range, lots of skills and experience to contribute through the session, through the delegates, in addition to our panel. Our programme is very much safe space, so we're here to facilitate peer learning, and we really want to get from the programme those actionable insights that we can share a little bit more widely with trusts across the sector. We're delighted to be partnering with the Health Foundation in this work. As you'll know, they've got huge expertise in the improvement space, and we're benefiting from that and also from connections with their Q community, which is a community of 4,000 improvers, all with different knowledge and expertise in improvement techniques. So this session is really timely because we're particularly interested in this session and the links between improvement and place. So improvement in that kind of place-based context, really timely given the bill was published this week, which will hopefully remove some of those sort of barriers and really enable collaboration. So we know that improvement doesn't stop at the front door of the trust, and I'm sure that you spend as much time in different partnership arrangements as you do focusing on particular improvement techniques and with your staff. So in terms of the running order, really delighted to give a really warm welcome to our panel today. First up, in a moment, we're going to invite Dr. Amar Shah to give us some of his insights. Amar is Chief Quality Officer at East London NHSFT and National Improvement Lead for Mental Health with the Royal College of Psychiatrists. We'll then take a little bit of time for a few questions to Amar if you have them. And then we're going to invite Glenn and Alison to do a joint presentation. So Glenn Burley is Chief Exec of the Foundation Group, which comprises Wye Valley NHS Trust, South Warwickshire NHS Foundation Trust, and George Eliot Hospital Trust. Hope I've got all of that right. And Alison Bolton is Associate Director of Improvement at the same. And we'll have plenty of time after Glenn and Alison have given us their perspective to ask them a few questions and then to pose questions to our panel of three as a whole. So just before we kick off, I'll do the obligatory Zoom housekeeping, and I'm also going to give you a little bit of a recap of what we've learned so far as we've done these webinars, and then I'll invite Amar to give us his perspectives first up. Next, just going to share with you, and I think colleagues have got some slides to put up. Just by way of background and just to frame our conversation a little bit, we thought it might be helpful to share some of the learning that's emerged from the previous two webinars that we've done. That's not to confine this conversation in any way, just thought it might be a kind of helpful backdrop before we start. So there are, I think, three key insights and then some kind of core principles emerging from what we've heard so far. So the first one you can see here on the screen is that trusts have been really interested in how they manage that tension between kind of top-down command and control, which we saw come to the fore in the pandemic, sort of inevitably, and that more bottom-up enabling others to act, and kind of getting that balance right has been quite a point of conversation. And to be honest, different perspectives on how best to achieve that. Next slide, thank you. Similarly, we've had a lot of debate, perhaps not surprisingly, as to how different trusts are either adhering to a particular improvement method or simply understanding the principles and developing something that's more tailored for them in their environment. So the last webinar, we heard two very different perspectives from a trust that had embedded very thoroughly a particular methodology versus a slightly more organic model. It's really interesting. And finally, again, a lot of conversation, and we might touch on this today in terms of really drilling down into what our speakers do in their trust, getting that balance between quality improvement and assurance. So kind of getting the governance right, but making sure that governance doesn't kind of stifle that activity and that improvement. And finally, some shared principles that are emerging. It's really interesting, despite the fact that all of our contributors so far have been adopting a slightly different approach and a different way of driving improvement, different methodologies. We found that there are a number of shared principles, and hopefully today's session will perhaps reinforce this and build on this. So all of the trusts we've heard from thus far have really sought to bind people together behind a common goal or common purpose and articulated that really clearly. The board has been really clear that they are supporting a continuous focus on improvement, and there have been really consistent messages from the trust leadership team in that regard. So that's been very telling. Setting the right pattern of behaviour and tone around improvement, including tolerance of failure, learning from mistakes, etc., has been very important. And all of our speakers have been inspirational and motivational. So they've been driving their staff and encouraging staff to come forward with ideas. Therefore, there's been a significant focus, as you'd expect, on engagement and comms throughout the organisation. I'm sure we'll learn more from today, but that's kind of a flavour of the kind of common themes that have come out of the first two webinars that we've done. And we'll be using today to inform our influencing work, what we say on your behalf as NHS providers, and also to refine this programme so we get the support for you right as we go forwards. So without further ado then, it gives me great pleasure to hand over to Dr. Amma Shah, who I think is our first speaker. Amma, are you ready to give us some of your reflections?
Yeah, thanks very much, Miriam. And hi to everybody. Thanks for joining the conversation this afternoon. I'm Amma. I'm a clinician and an improver. I've had experience of applying improvement within a provider across an ICS. As East London Foundation Trust, we span 2 different ICSs, so trying to apply the principles of QI and the method of QI across 2 health and care systems, and also support large-scale improvement across countries and whole healthcare economies in England and around the world. So I'm going to bring some of my reflections on this question, knowing also that I don't know the answers to this, because this is something we're going to have to work out as we learn our way through it, given it's quite a new challenge for us. So I thought I would start by beginning with content that we probably are all familiar with, but I think might ground us in this conversation. This conversation is all about quality improvement, and I think we should start with what quality improvement brings to a system. What good quality improvement is a systematic approach to solving a complex problem. And I guess we need to think about that in the context of the integrated care system and place-based approach to health and care delivery, because the complexity is only going to increase. So having a systematic approach to working our way through and learning through complexity is going to be a real asset to us. QI also depends right from the outset on systems thinking, and having an appreciation of systems thinking, again, is going to have to be critical in navigating our way through and delivering outcomes for our local populations. Any good QI work involves a range of stakeholders. So people who've been experienced in QI will already be familiar with how to involve and engage a range of people in this work, often outside of their usual microsystem, their usual team. So they may well be involving patients. They ought to be involving patients in their work. And automatically there, you're working across a very clear imbalance in power, usually, and trying to address that in the way you do this work. Often you'll be working across multiple teams to improve a pathway or a system around care delivery. And so QI already brings skills and experience with working across boundaries, which we can leverage when we think about applying the same approach within a place-based system or an integrated care system. And finally, good QI doesn't sit in isolation. So any organization that's ever tried to adopt quality improvement has at some point realized that QI is not a project or a program of work. It needs to be part of a management system and needs to sit within a holistic management system that also aligns it with planning, control, and assurance. So those 4 aspects are core components to any management system that's really focused around quality. And I think grounding our conversation in that might help us think about how do we really consider how to apply quality improvement across place-based systems or even across an entire integrated care system. And I think I came up with three thoughts really that I wanted to share about opportunities for us and places where we might want to be paying attention when we think about how do we apply QI now outside the boundaries of a single provider and into the ICS. First of all, leadership. So quality improvement is not just a method or a set of tools. It's a mindset as well as an approach to problem solving. So I think we need to be really mindful about how do we help people consider and reflect on their approach to problem solving as leaders, and try to get to some unified thinking about how we're going to approach the sorts of problems we're now facing and the sorts of issues that we want to be able to work through together across a health and care system. Because unless and until we really come together around a mindset that we all agree on, it's going to be hard for our behaviors to follow from those beliefs. And without leadership, we know that quality improvement struggles to thrive. So the leadership behaviors that quality improvement requires are very different to the leadership behaviors you need in a hierarchical command and control structure. They're much more around curiosity, on getting close to where the work is, around playing an active sponsor role. And they are different kinds of behaviors, coaching behaviors, enabling behaviors, much more than directing behaviors. So my first thought is really about leadership and how much attention we're paying to making sure our leaders are on the same page around the way they think about the problems that they want to tackle. The second is about language, and what quality improvement brings is a common language. So in any provider that's tried to adopt QI, you'll realize the power of different teams, different professions who've been trained so differently, working in different content areas, having the single language of improvement to learn together. And so we need to build that common language across the system. And it may be the case that healthcare providers already have some fluency in that language, but large parts of our health and care system don't have the same fluency with that language. So we need to build that. And so I would say one critical component, and in fact, an enabler for this work is going to have to be to build skills in quality improvement across the entire health and care system, including citizens, including voluntary sector and non-traditional providers of health and care. And then the third is about capacity. Anyone who's tried to do this work in a provider knows that you can't just ask people to add on QI to their work. You need to take away work of lower value. You need to find capacity to support this. QI relies on leadership support, and it relies on close, skilled improvement support. And so we have some real opportunities, I think, to think differently about the support structures around commissioning and around health and care systems, and how we might be able to use those differently to provide skilled improvement expertise. Because one common thing I'm hearing and seeing is that providers have quite a lot of capacity and capability and improvement. Surely they can just support place-based and ICS level QI. Well, I think that will just rob Peter to pay Paul. I think we need to really make sure we don't detract from the infrastructure we built within providers, but build on it when we start thinking about place-based and ICS level improvement work. And I think we will need to find new capacity for that and build people's skills. So those are the three thoughts I had about really high leverage points for us to consider when thinking about how we might adopt a single approach to quality improvement across a health and care system. Leadership, language and capability around improvement, and thirdly, capacity. And I just wanted to finish off by thinking about what can boards do in this conversation, because recognizing that most of the audience today are going to be board members. And a couple of thoughts came to mind. One is reflecting back on some of the earlier conversations in these previous webinars about governance and assurance. And one thing boards can do is really help with shifting the attention away from structures to relationships and the way we do our work. There's an over-reliance on trying to come up with the perfect structure or the perfect committees or the perfect ways of governing work. And my sense, my theory behind that is that it gives us a sense of control. It gives us a sense that we have some control over the system if we can see how it all feeds up. But actually that, for me, demonstrates a misunderstanding of how to lead for quality improvement. If you lead an improvement-focused system, you shouldn't be reliant on a governance structure to feed you information. In fact, if you do, you're not really being an improvement-minded leader. improvement-minded leaders will be out at the point where the improvement's happening, where the value is being added. They will be directly connecting with the teams doing the work, and they'll be thinking about their role as being about enabling, creating the environment in which this can happen rather than managing by exception. So we need to pay much more attention in the development of our ICSs to ways of working. And when I've looked at many STP development plans, as an example, there's often not even any mention of quality. And for me, that's a major gap for us. If we're thinking about the future function of ICS and are not even mentioning quality, what's the purpose? I mean, the core purpose of health and care is around quality of life and quality of care. So if we don't have a plan around quality, I really struggle to see what the point is of the ICS. We often have finance plans, and we often have clinical leadership plans and workforce plans, but nothing really around quality. So let's make sure and advocate for best practice thinking and approaches to quality in the way that we develop our plans for the integrated care system. And when we do that, let's make sure that it's seen as the core purpose of the ICS, to improve people's lives and improve people's quality of lives, and make sure we bring best practice thinking around quality to that, rather than see it as a program of work or a project, because that never works in a provider. It has to really be adopted as the way you think and breathe and live, and be the core function for it to really be embraced as part of the way you approach work and solving problems day to day. The second, my second ask of board members when we're influencing and being part of these discussions around the integrated care systems and how we might adopt quality improvement is to advocate for quality expertise to guide us in this process. I'm here as a chief quality officer. I'm also here as, I think, the only chief quality officer in the UK. And I don't know how many boards across the country really have genuine expertise in quality sitting at the board when they're thinking about how to provide high quality care. And it's not the same as medical expertise or nursing expertise. There is a specific expertise around quality and quality management that we need to bring to this conversation. So, and my second ask of boards is to advocate for quality experts, people who really understand quality management and quality improvement, to help us think about how do we design an integrated care system that doesn't just create a program of work for QI, train a few people and run a few projects, because that's not the same as creating a culture of improvement across a complex system. But how do we really try to start to build a culture of continuous improvement that sits within a management system where it's really clear what our approach to planning is and how it links to our improvement efforts, how that leads into control systems, and how we use quality assurance to help provide assurance around standards of care. All of those should link together and align together in a holistic management system. And for that, I think we do need people who really understand this work and the evidence base to help guide the design. So those were my thoughts, Miriam, about 3 high leverage points around leadership, fluency of language and building people's capability and creating some capacity at place, space and ICS level, and 2 asks of boards. First, to advocate for quality in the way we articulate the ways of working and thinking in the SDP and move away from structures and governance forum. And secondly, to advocate for quality expertise alongside us as we start to design what the ICS looks like.
Thank you, Anna. Such a rich intro for us. And I'm gonna open the floor for questions from the audience. I can see one hand up, which is great already. I'll just kick us off, and then I'll come to you, David, because I can see your hands up. I wondered, Amma, just to kick us off, is there any more you could expand on from your experience about how you've kind of built that consensus, that kind of leadership mindset, or that consensus around language? I wonder if there are any sort of practical examples from what you've done you could share with us to kind of illustrate how people might make some of those really helpful steps.
Yeah, I think it's a very individual thing, Miriam. I think it's when I think about how to really build belief amongst leaders that this approach to operating is going to be better than our status quo, we need to really help people feel it and believe it and see it for themselves. And people are influenced in different ways. So I would always think about what's going to be, how does someone interpret information, what's really going to be connecting to them personally. And when I think about leaders and influencing them, I would be considering a wide range of possible ways of doing that, whether it's helping bring them to the place where work happens and showing them examples, or whether it's about providing the literature and evidence base, which may well be influential for others, or whether it's talking to other peers and hearing it from someone who's in similar shoes and has gone down this path before. So I don't think there's a one size fits all for this. I think when it comes to influencing leaders, we're really trying to build belief. It's not enough to understand this academically. You have to truly believe that this represents a better way of being, because you're going to have to live and breathe this as a leader and change the way you might have been reinforced to manage and lead healthcare systems up till now, to really adopt a much more collaborative, improvement-minded way of behaving as a leader. And you're going to need to believe that truly and deeply and authentically in order to practice it.
Thank you. David, I can see your hands up. Did you want to come in with a question?
Yes, I think we've got a lot of emphasis and we talk a lot about improvement, and I've seen a lot of improvement initiatives in the NHS, and we've gone through, trusts have traditionally gone through an annual cycle of cost improvement programs. And that's actually, if you look at how they are set up and how they're run, there's a lot of, if you like, cajoling to find new projects, improvement projects, which I think is interesting, because I've done, my background is operations strategy, and I've done a lot of work also in Japan as well. And one of the things that they do is they don't actually focus on improvement. What they actually focus on is recognizing waste and recognizing inefficiency. And they organize processes to very quickly identify where there is waste. And what is interesting there in terms of the management dynamic is that you actually empower people to feel comfortable about highlighting problems. And the next step then is, how do you then organize yourselves to deliver improvement and actually reduce that waste? And so, I'm not sure we do that very well at all in the NHS. And we don't have the measurement mechanisms to identify the waste, if you like. And waste, it can be a process waste, it can be the, lost outcomes, it can be lost quality of life, it can be, whatever it might be. But, I think in the first step, we have to be clear on, what waste are we trying to improve on, and then how do we move forward from there?
Thank you. Anna, do you have any reflections on how you've approached that in North East London?
I think the best places, David, do have ways to connect people to what really matters and have that common purpose and shared purpose together. Improvement is not the goal. Improvement is a means to achieve the goal. As an example, all of our work at East London Foundation Trust is wrapped around a single question: what matters most? And we get our teams of staff and patients to think together, what is the biggest thing that we really want to work on and improve together? And that's what drives the work. And good improvement will bring with it, if you do it rigorously and robustly as quality improvement should be, then it will bring really good measurement with it. So you'll be able to demonstrate the impact. And if you can't do that, you've got very little chance of convincing others to join the journey.
Thank you. Well, we'll have plenty of time at the end of the session for more questions to Amma and the rest of our panel. But now, if they're ready, I'm going to hand over to Glenn and Alison for their perspectives. And Glenn, I think you're first up and with a slide. Is that right?
I am. If someone could put our slides up, that'd be great. Afternoon, everyone. Firstly, what Amal just said was brilliant. So everything he's just said, I would certainly concur with. So you're going to hear from me. I'm chief exec of the group, and then Ali, who's our our improvement lead, who's going to give you much more context of what we're doing. I'm going to describe the construct of the group, and I think that slide has gone away. So if we could move to the second slide, that would be great. So firstly, the foundation group is a little bit unusual in that I suppose we should now call it provider collaborative, because that's the word that we're used to, and it's the provider collaborative that's a shared leadership model. It's 3 trusts, and their names along the bottom of the slide, and Miriam read them out earlier, who have a common shared purpose. So in the top right-hand corner, importantly, is our shared strategy. And that was a strategy that was first developed in South Warwickshire Foundation Trust, then tested out in Wye Valley, and then tested out in George Eliot as they joined us. And what it is a strategy to be the lead provider for integrated care in the places that those 3 trusts operate in. And those places are quite far apart, actually, which is the unusual part about our group. So there's about 100 miles difference between the span of the edges of the group. So from Powys to Polesworth is the edge of the group. And we're not neighbours either. So between South Warwickshire and George Eliot, we have Rugby and Coventry, and between South Warwickshire and Wye Valley, we have Worcestershire. But what binds us is that common purpose. And I think that's one of the really important things about working together in a group or an improvement is having that single kind of shared common purpose. But the ability of us coming together to create scale is one of the most important things about the group. We're a relatively lean structure, but by bringing those 3 organisations together, we have a turnover of just over £800 million. And that allows us to invest in some assets. And one of the assets you're about to hear from in a moment. So Ali is our group improvement lead. And as Amar said, you do need to invest in the expertise in this. I often refer to Ali as one of the black belts in improvement. It's in everyone's jobs and needs to be in everyone's jobs, but it's important to have some people with the skills to lead, not just the training, but the equipping of staff, the sharing ideas and experiences. And if our chairman was on this call, he'd talk about his mantra, which is sharing best practice at pace. So we've got quite a permissive approach to improvement methodology. That means that you can make mistakes, but the idea of the group is you ideally make them once and then learn from them in the other 2 organisations and connect people who have worked on those individual projects to ensure that we share best practice. So what we try to do in bringing together the 3 cultures of the 3 organisations is, firstly, there's no hierarchy in the group. So it's not led by one individual trust. I happen to have been around South Warwickshire for longer, but Wye Valley and George Eliot, as they joined the group, they all have qualities and best practice that the rest of the group has shared from. And therefore, what we've done when we looked at the group-wide approach to improvement, we had a look at the improvement methodologies being used in all 3 trusts. So firstly, we spotted that in George Eliot, they've done quite a lot of work on shared governance. So that's about empowering teams to take responsibility for the delivery of their services to make improvements. And so we could see that was working well. So we put that into the group model. We then looked at the work, particularly that Ali had been leading in Wye Valley on QSA, and deduced that was the right methodology for us to back. So that enabling methodology of QSA is in our approach. And then finally, in South Warwickshire, we've done some work with the Health Foundation over the years on Flow Academy, which is looking particularly at acute flow, but then into system flow, which is more of a coaching approach. So we've got an empowering, enabling, coaching methodology, and all those 3 things come together in the mix of how we bring together improvement across the group. So I'm now going to let Ali talk about some of the detail beneath that.
Thanks, Glenn. Hannah, if you could move the slide on one, thank you. So guys, hello, and I guess thank you for inviting me along today. I'm going to spend the next few minutes talking about our approach and how we have spread that out into PLACE and into ICS. So as Glenn said, we agreed a single approach really early on in our improvement journey. It was really important to us because, and I'm so pleased that Amar talked about that language of improvement, because that was quite specifically why we went down the route of a single approach. Having staff who have access to that common language and that common understanding as well, it's a complete joy to work with staff when those pennies start to drop and they start to use the language of quality improvement, and it brings their projects to life, and things actually start to move at pace in a way that they maybe hadn't done previously. The other thing that I would say about, so I don't come at this as a quality improvement guru, but I'm all about improvement, and I don't mind whether that's quality improvement, service improvement, or cost improvement. That's my bag. I believe the tools and techniques that we use are applicable right the way across the board. So in terms of our improvement journey, our roadmap got a little bit of a wrinkle in it last year due to something that you might have heard of. So in stumbling through COVID to come out the other side, if indeed we ever do, we started to offer a virtual piece, which came to us from the national team, but we've adapted for local need. But it has allowed us to retain engagement and momentum with our staff. So we didn't park the work that we were doing. We've integrated all of that. I mean, the COVID came along and kind of derailed everything, didn't it? And everything, we had one job to do at that point, and nobody was terribly interested in me banging on about QSA, for example. So there's a time and a place, I think, but we are now back on track. And what the virtual offer has enabled us to do is to deliver much further than the doors of our organisations. We offer it out across place and across ICS, because it actually makes no difference how many people are sat in a virtual room. Glenn's already mentioned the fact that our group works in 2 ICSs, and we're in 3 places, and we're in 1 group, and it's vaguely messy. Some days I have slight schizophrenic moments, but the reality is this methodology and the tools and techniques that are available to us are things that we can kind of spread quite widely, and therefore the language spreads and allows us to move at pace. I'm really quite driven as well by making this activity real. Improvement should not sit in a classroom. It's improvement's a doing word. You kind of need to get out there and get on with it. And Glenn regularly gives people in my classroom permission to do exactly that. So we work quite hard to ensure that the programs and projects that come through the classroom are very, very well grounded in the reality of the NHS. We make sure that they are connected to the services, the teams, the departments that the projects are going to sit in. We also make sure that the people coming through the educational route have got access to service improvement professionals, so that if they're struggling and they need a bit of coaching, they've got somewhere to go. I think we've mentioned failure several times during this session. Fabulous failure, it's one of my kind of strap lines. There has to be room for failure in improvement. We can't get it right all the time. And the reality is we learn so much more as humans by getting it wrong than we ever do by getting it right. When I get something right, I kind of might pat myself on the back and I get on with my day job. Great, done that, fantastic. When I get something wrong, I take it apart, I unpick it, I analyse it, I work out what went wrong. And I learn so much more about that thing than I ever do were I to get it right first time. So fabulous failure for me is it's a moment of learning. So take it and run, I say. It's great, just embrace it. In terms of what we do across the group to share, there's lots of options available to us, I'm sure, as you can imagine, but we have in one of our organisations that's kind of slowly spilling to the other 2, something that we call Transformation Tuesday. And it is a way for us to engage colleagues at place in the development and progress of projects. So we come together every other week to talk through projects that are spanning place. So they're not sitting in one health or social care environment. They're kind of spread across us, across the partners. And we feedback, we update, we provide a report on the progress that we've made. And there's a huge amount of sharing and connections and networking that happens at that point. I know if anybody was interested in attending that, just to shadow to see what that looked and felt like, I can get you an invitation. Just let me know. The Group Improvement Network is something that I started last year. You'll notice that it's got a superb acronym. So you can come to the gin if that's what you want to do. And it's full of programme, project and improvement types from across the group. Very much a networking environment. We learn, we share and we grow together. Very informal, lots of giggles actually, but I'm a big believer in, if people are enjoying themselves, they're learning. So yeah, we love the Group Improvement Network. And then thirdly on there is the Group Improvement Library, which is, so it's in its early days, but this is somewhere where we can share our case studies, our videos, our publications, anything that we want to share across the group. So yes, that's in progress, but it is coming. And finally, what I wanted to share with you is the blue box on the screen. And again, this has been alluded to throughout the session so far. We try very hard to offer our staff support to improve, but it's more than that. We give them permission to improve, and permission goes two ways, doesn't it? So I can give you permission, but actually whether you're willing to pick that up and run with it is another matter. So that trust between kind of senior members of the organisation and those people on the ground that are actually doing it is absolutely crucial. And actually, if you can get that right, if you can give people permission and trust them to get on and do great things, they will simply make great things happen. We've seen that. Projects fly when people believe in what they're doing. They know they're doing the right thing, and they know that we've got their back. So yes, permission and trust, I think, are core to everything that we do and are at the heart of our improvement journey. Thanks, Hannah.
Thanks ever so much, Glenn and Alison. Really, really interesting presentations and so much that echoed, I think, what Amar was saying there. So audience, please do put your questions for the panel in the chat or give me a wave. I'm going to come first, I think, probably one for Glenn and Alison, but then maybe Amar as well. I'm just interested that you've rolled out a kind of consistent approach to improvement, your single approach. I just wondered for others that are striving to do the same or at a different place in their journey, did you come up against any barriers to that, or were there any obstacles you had to overcome? I wonder if you could just tell us a little bit more about your kind of experience of how you went about that. Maybe
perhaps if I start on that. I suppose one of the things I was worried about from the start was and this sometimes has happened as the group has evolved, is you can get this kind of not invented here type response to things. So I suppose we did deliberately seek out good practice in all three organisations and blend them together, so that each trust or the staff in each organisation could actually see something that they'd helped to create in that kind of ultimate model, and that made it much more palatable for everyone to be involved in. And then it was just simply the fact that we then teach people a common language of improvement. And I suppose that as well as the cross-group work, as Ali said, the kind of within-place work has been important to that as well. So we made the decision quite early on that all of the training and development that we do within the trust, we would make that open to all place partners, free of charge, so that they can join in with this, and as well as having the same language, they're obviously learning together and creating networks.
Fantastic. Ali, is there anything you'd add to that?
Yeah, I guess so. As I love CUSA, it's a brilliant program, and we use it across the group. That is our approach. But it's more than that. So CUSA has a vast suite of tools, tips, tricks, techniques in there that we share readily. But no amount of those things will make improvement happen if the people aren't coming with you. Amar mentioned it earlier. It's leadership and trust and permission. Yes, absolutely. But people need to buy into this thing. It can't be something that sits in a classroom or something that sits in a specialist team. What we do, the group is made up of 3 small organisations. We haven't got a massive pool of people who specialise in improvement. It's everyone's job. So us educating staff in the tips and tricks around this is one thing, but there's also that coaching layer around how we engage others to come on that journey with us.
Fantastic, thank you. And Anna, a slightly different twist on a similar sort of question from the audience. So Jem's asking, how do you translate permission from the board through to frontline managers who can sometimes be the barrier to teams engaging in improvement? I wonder if you've any experiences you can share with us of how you've managed to make that golden thread work effectively.
I don't know that we have made it work effectively, but I guess, when you're leading this kind of effort, you're making quite a lot of time to try and understand what matters to people in their different roles and how you can connect the purpose of improvement to why people come to work in the morning and what will help them do their job better. So I find that you do need to take special care to make sure that this group that's sort of in the middle, in the sandwich, often we spend a lot of time at the point of care. We spend a lot of time with the leadership, and this group that's in the middle is so critical to culture and the way things get done. We don't spend as much time with that group, but actually understanding what's on their plate, because they probably have the hardest job of all, of translating the hundreds of instructions and guidance they get and trying to make sense of that and then help their teams at the point of care with the challenges they face. And seeing for them, how can improvement help them with that? How can a consistent and holistic, single approach to quality make it simpler for them to do their jobs more effectively and enable them to allow their teams to lead much more? Often they feel like they are holding the burden of improvement and making things happen, whereas actually, again, for them, part of the joy of this work, I think, is in seeing that their patients and their teams can actually lead this work and their job becomes a little bit different and more fun.
Thank you. And colleagues, I will pose all of your questions. So just ignore the fact that I'm not doing it in strict order. Just while we're on common language, I just wanted to pick up interesting question from Tony Ellman. So perhaps first to you, Amar, and then perhaps come to Glenn. What is your experience, I suppose, of creating that common language with some of our non-NHS colleagues and partners?
I think it's a great question, and it's a real challenge. My firm view is that we overcomplicate quality improvement. At its principle, it's quite, right at its heart, it's pretty straightforward. When I coach a team, I try not to use any jargon at all. You can do quality improvement without ever mentioning a run chart or a PDSA. You don't need to. And actually, we need to draw it right back to its core principles and have really skilled translators. Really skilled improvers will be able to translate and make this happen from people from a variety of different backgrounds. And part of the skill of this, I think, is comes through working with patients and our local people and involving them in our improvement work, because they will help us learn how to do this work in a way that's jargon free. But we absolutely need a common approach to this, and we can do both. It's not a choice. We have to have a single approach to improvement. We can't have part of the system doing it one way, another part doing it a different way, because we'll never learn from each other that way. But we can do it much simpler.
Thank you. Glenn.
Yeah, I'd certainly concur with that. It is simple if you look at it properly. I think the measurement side of it is one of the most important things to me, that a lot of people try and do improvement without using proper measurement and time series data. So some of those techniques are quite important to get people to look at it differently. But every time we work with different groups, we see this from a different perspective, I think. One of the things that was most interesting for me the other week. We've just employed a public health consultant as part of the trust. And so we were talking about his perspective on how you can look at improvement using prevention. So rather than looking at how we fix this thing or do this thing that we're doing in a quicker, better way, it's actually whether we could stop it happening in the first place through an improvement methodology. So that's been a really interesting dynamic. So bringing his thinking into the way that the teams tackle problems means that you kind of a broader set of solutions come forward.
Really helpful, really interesting. And I'm just interested, maybe building on that slightly, Glenn. There's a question here from James, and one of the questions that we wanted to ask actually is interested in your perspectives about how you bring improvement together with other drivers of change. So you sort of mentioned the public health angle there. We've also heard from members that some of them are interested to bring together their digital transformation program, for example, with their improvement approach. Some trusts have improvement integrated with organizational development. So I don't know if you've any reflections around how you get that, I suppose, integrated approach to improvement, incorporating all those different drivers of change.
Yeah, I think you've got to avoid silos. Our improvement board, for example, looks at a whole breadth of things. I mean, we happen to have, because one of the other group assets is a digital lead, and we've got a digital improvement hub in one of the trusts. But digital is just another methodology for solving problems. I think what brings it together is that kind of shared single vision for the future. So on our charts there, you looked at the strategic wheel, as we call it, which is the integration of services. It's that single uniting purpose, which is to make things join up and deliver the absolutely best outcomes for our population. Improvement, digital, and someone mentioned cost improvement programs earlier. We stopped using the word cost improvement because that was another silo that was sometimes just the domain of the finance team. We refer to cost and quality improvement and productivity improvement now. So I suppose what we're saying is we make it part of everyone's business. We've got an improvement board that brings those threads together, and our various leads in all of their domains work as was more of a cohesive team. So yeah, try and avoid the separation of digital from improvement, because digital is just a means of improving.
Really helpful. Amma, I don't know, did you want to come in on that one around sort of how you integrate those different sort of drivers of change?
I think the first point is that we shouldn't see quality improvement as purely being in the domain of the clinical world. We apply quality improvement, as Glenn's just said, to every part of our operations. Even our Council of Governors has used improvement to improve something that really matters to them. Our trust board uses improvement on something that matters to them, which is the volume of papers they have to read before each board meeting. So there's opportunities to use it in everything we do. And I guess the second thing around digital is that we can't really think about improving any process these days without considering digital change ideas. So for me, it's an absolutely core change concept in any kind of improvement activity.
Thank you, really helpful. I'm just going to pick up now on a question from Sarah Phillips. So Sarah's asking about how you bring someone to the place where work happens. So I think this is a question about the panel's thoughts and experiences on how we can most effectively bring board leaders to the place where work happens or change happens. Hope I've summarised that effectively, Sarah. But I think this is a question about how we most effectively get board leaders where they need to be, and your experiences of that.
Yeah, and that's a really interesting question. I suppose what we try and do is open up the improvement work to anyone. As Alice just said, the Transformation Tuesday work is an open invitation, and we've certainly had non-executive and executive board members join in with that. What we try and do is encourage them to be quiet and listen and learn from it. So I suppose the thing that I would want boards to focus on is creating the culture and the environment and the permission for clinicians and non-clinicians to actually come into work every day with that spring in their step, where they're willing to try different things, and where they know that if they get them wrong, we're not going to jump on them and criticize them, that we're going to work with them to find out why it went wrong, as Ali said, and make it a little bit better next time. So that continuous improvement methodology. So I think boards, the responsibility for me for boards is the culture of this, the permission and the environment that makes it okay to have that fabulous failure, because the next time you do it, it will be the fabulous success that you kind of then spring back into your workplace into the next day. I mean, Ali, you do this every day rather than me occasionally doing it, but what's your perspective on that?
So I think our introduction of improvement boards into each of our organisations has brought kind of small and large improvements really kind of the front and centre, because the improvement boards are very much made up from our executives. So all of those people are sat there hearing anything from a small CUSA project that's happened in a single team where they improved efficiencies, right the way through to something extraordinarily transformational. And we bring case studies into that environment to share with board members to ensure that they do stay connected to what's happening on the ground with our staff. Absolutely crucial that they understand kind of both ends of that, because actually, even for those small improvements, it's incredibly meaningful for those people on the ground.
Thank you. I love the concept of fabulous failure. I'm definitely going to adopt that myself.
You can have it. It's all good.
Steal it. Amma, did you want to add to that from your perspective? Because you had your very clear asks of boards, didn't you, in your presentation?
Yeah, I think there can be an illusion when you're, in a senior leadership role about quite what the work involves. And the closer people get to it, the more they can understand the true nature of it and how they can best support. And they can feel it, the impact that it makes too. So we were talking earlier about how we can encourage leaders to really believe that this represents a better way of leading and running a big health and care system. They can't do that unless they feel the impact personally. So getting out of the boardroom, spending time out with teams, as an executive team, for example, we every week, it's part of our standard work to go and spend time with the team. And we do that with 300 teams a year. As a board, every board member goes out and hears from teams that are using improvement about what it's been like and how difficult it's been, but also how people feel about it now that they've found a way through. And that helps reinforces their belief that this is a better way to solve problems. I think the final thing I would say is board members can really help by holding each other to account, really, whenever we see each other start to solve a problem, because really the worst place to solve problems is right at the top of the organization. So, but it's a really attractive thing to do because we see things as much simpler than they actually are from our vantage point. So when we see that happen, just check each other and say, hang on, are we really the best people to do that? Or should we take it out to where someone's probably got better ideas?
Thank you. And just building on that idea of, I suppose, learning from both failure and others' achievements, we've got a question from David about, I suppose, how you build a library of achievements, or kind of how you share that learning a little bit more widely across the place or across the system.
Ali, do you want to talk about your library?
Yeah. So the group improvement library is something that we're building, and it is based on. So anyone that comes through our improvement programme presents us at the end with a case study of their experience of working through that piece of work. Now their project may not be complete at that point, but the progress that they've made and the tools and techniques that they've used are the things that we're interested in. The fact that they have taken on board and understand how to improve in a systematic way. So those case studies are finding their way into our digital environment. George Eliot in particular are really singing and dancing from a on a video platform around what they're doing and how they're doing it. So those videos are being captured about people talking through the improvements that they've made, and you really do start to get a feel of that genuine joy in work. When people are succeeding in their improvements, they do start to sing and dance about it, which is just glorious. I love it. So all things improvement, we're kind of funneling into that space so that across the group, we've all got access to it. But more importantly, what we're trying to get to there is, so if I'm sat in Wye Valley and I think I need to do a falls project and it needs to be about this, what I want to do, what I want people to do is to think group first rather than just Wye Valley. So there will be somebody, pound to a penny, there'll be somebody in the group that is already doing that project, or that has done that project and has some experience in that environment. And there's something about just pick that phone up, have that conversation, share that learning, and then crack on and do your project. So lots of layers to that, but the digital space that we're building is key to it.
Fantastic, thank you. Colleagues, please do keep your questions coming in, because we've got a fair few minutes and I'll use all of them. Meantime, I'm just going to take the liberty of chair's privilege to change tack a little bit and pose a PhD question to Glenn, so I hope you're ready. I think a lot of trusts are thinking through how they balance accountability between those system levels, the group level, which you have, and then an individual trust level. I just wonder if you've got any reflections on that, how you get the accountabilities right at different levels of the system, and also perhaps how you then apportion your time appropriately, given that you're all very, very stretched now as leaders across these quite large footprints.
It's quite tricky, Miriam. I think we're working at so many different layers now. So, you know, as you say, for us, there's kind of trust level, then place, group, ICS, we're across 2 ICSs, and there's some things that go kind of bigger than that in some of the provider collaborative work. So we're part of the Association of Groups, and there's some really good work that comes out of that. So I suppose the clarity that comes around the accountability of individual organisations, I suppose, is one thing we need to not lose in all of this, because I think whilst we absolutely should have place-based clinical strategies and development strategies, I think that kind of the governance of the NHS is built on organisational governance, and I think that's where we're trying to get this balance right with the ICS legislation to actually retain that organisational governance and the audit that comes alongside it. But Amar made a really good point earlier, which is, let's not stifle ourselves with governance, because we need to learn more across the NHS. We've moved from an era where there's competition to hopefully an era where there's more collaboration and sharing, because that opens up learning for us. But I think people often think too much about the governance. And that's what I worry about the next year as we build up to April 22, that we could spend an awful lot of time getting governance in place and not enough time doing things. So I suppose my responsibility as chief executive of the 3 trusts is to try and free people up from that, to try and declutter that, encourage them to be clear about where they're trying to take their system, their place, and focus on that, and focus on making improvements every day and progress every day, rather than how we then account for it and assure against it. Because if we concentrate too much on the assurance, we'll just not do anything. So I think that's board responsibility to create that, to declutter within the group. One of the things I'm most proud of is the way that we've, as chief exec, my role has become a little bit boring, because I tend to go to some of these governance things that kind of go on at system level. The managing directors that on a day-to-day basis run each trust are freer to get on and do the more interesting things. Sometimes I wish I had their job rather than mine, because they're not cluttered by it. We need to make sure that we don't create a really cluttered, crowded space.
Thanks, Glenn. And Amar, perhaps a spin on that question for you. Be interesting to know how you've built capability, I guess. You talked about building capacity and capability across the system. I wonder if you've seen an increase in capability for improvement by bringing teams together across the system.
Yeah, I think so. And I'd be surprised if most teams who are doing QI work at the moment in a provider aren't already involving some kind of external stakeholder. Most of our teams, when they're trying to improve, are involving a commissioner or a local authority team or a care home. It's just that's part of the system that's contributing to whatever it is they're trying to involve. So all of those folk are part of our improvement effort. They join our training, they join the teams doing the work, and that gradually builds fluency. When we've tried to do this work wholly outside of Elft and in the system, owned by the system, it's had sort of varying success over the last 4 or 5 years. The first time we tried it, put quite a lot of effort into it, it didn't really succeed very well, partly because the system just wasn't ready for it. The leadership didn't quite comprehend how they could support it. And despite well-meaning effort from people at the point of care, it just didn't go anywhere. It's having much more traction now. And I think part of what we need to do is build the case studies to show how you can really use QI across multiple partners and improve outcomes. I still see very little stories or published evidence about that, and we're doing our best to tell as many stories as we can and publish peer-reviewed literature about this stuff so that people really believe that it works and have the evidence to back it.
Really helpful, thank you. And actually, I'm sort of building on that. Ernesto is just asking a question here about your experience of partnerships with experts, either Virginia Mason or IHI or the AHSN, because you talked in your presentation about the need to recognise QI experience as a particular set of skills and expertise. So I wonder, can you give us any reflections on learning from other partners or kind of how you've built that within North East London?
So I think there is a role for people outside of the system to help us as well. They can provide some expert guidance. They can be a critical friend. They can help us see things that we might not be able to see inside the system. But when we began this journey in a single provider at Elft 8 or 9 years ago, there was really very little in the system we could draw on for support. The world has changed massively. Really, we have quite a lot of internal capability within the health and care system in England. So I'm not sure we need to look outside as much as we might have done 8 years ago when we partnered with the IHI, as an example. We still are partnered with them because it brings value to us. They're trusted partners. We get some support and guidance and coaching as a leadership team, and then we still do a lot more work together in true co-production. But I think integrated care systems are definitely going to need some guidance with this. People who can help them think about the system design, really being best practice management philosophy about how to really improve quality of care and quality of life, because there is evidence base and expertise out there that can help with this. And I think a lot of that can come from inside the NHS and inside the health and care system, but we may need some external help too.
Really helpful, and both we and the Health Foundation really interested to help shape what the role of ICSs is around improvement. They're building from the work of trust, so really interesting. Well, I think I've got one final question for each of our panel, if that's okay, and that is simply, what one thing do you wish you'd known at the beginning of your journey that you now know? I'll come to Amma first because he's on my screen, and then to Glenn and Ali.
Long a journey this would be, Miriam. I'm not sure I really went into it with eyes wide open about quite what the landscape would look like 10 years from when I began my first foray into improvement. And I might have thought a little bit more systematically about how to manage my energies and pace myself over that time. But I'm really heartened by the way in which improvement is being adopted as an approach to solving complexity in health and care systems over the last 10 years. It's now just seen as the approach we should all be adopting, and that's a great step for us to take.
Thank you. Ali, shall I come to you next?
Yeah, I'm mentally casting around thinking, what would I do differently? So I came into improvement from a program and project perspective. So wasn't what could kind of classically trained. I wasn't classically trained in improvement, and wish I had been. Probably many years before I actually undertook improvement education. The programs and projects that I managed previously, I think, would have had better outcomes had I understood the products available to me.
Fantastic, thank you. And Glenn?
Probably a similar theme to that one, actually, which is, yeah, I came late to improvement. I'm boring now. I'm an accountant by background. And I suppose some of the things that I've got right over the years, I've realised I've just been lucky on them rather than a good methodology behind it. So I actually, we put the whole board through Ali's training when we first said, all three boards actually of the trusts, and so that approach has changed the way I work, and I wish I'd known it earlier, because I wouldn't have made so many mistakes that I didn't learn from.
Thank you. And thank you all for very honest and rich presentations. We're coming close to time, so I'm just going to attempt to summarise the conversation, although very conscious I can't do the richness of that discussion justice, and then we'll talk you through some next steps before we close. So really struck by the kind of commonalities in what the three of our panels presented today, particularly around shared mindset, that need for developing a shared common language. And I was really struck actually by the fluency with which all three of you speak improvement, despite a couple of you admitting that you'd come to it slightly later in your careers. So really interesting messages also, I think, around building those relationships and investing in those over getting bogged down unduly in committee structures and governance. So a lot of common messages with what we've heard from others, and a lot of really interesting insights for us to take away. I hope the delegates have learned from those presentations as well. I'm sure that we all have. So Carly, I think you may have a prompting slide to aid me through the next things that we need the delegates to do. So bits that we wanted to flag to you all, which we're really excited about. In terms of next steps for the programme, we have gone out to invite expressions of interest for some new learning sets, action learning sets, which will be a free offer for our membership. So please do consider signing up for those. That's in train at the moment. We'll also be developing our resources in the autumn, and David will endeavour to make sure that those case studies are kind of measurable and they've got the outcomes in them quite right to prompt us on that. And we're also exploring some deep dives during the autumn, probably virtually. And by deep dive, what we mean by that really is that we take one or two much more detailed themes of improvement and really explore in much more detail how a particular trust has developed their approach to those aspects. So you get a much more kind of granular view of what a trust has done on a particular theme. Please do send us your expressions of interest, and I know colleagues will also be sending around the evaluation form. So please do look at that, because we do take your feedback very seriously and it will help us to shape the programme going forwards. We will also circulate a link to a recent publication that we've put out around collaboration with a number of case studies, all of which are relevant to improvement. And I think colleagues very helpfully put that in the chat box for you as well, along with the evaluation form. So really, it just remains for me to say a huge thank you to our panel, to Amar, Glenn and Ali, for your really rich presentations and for your time today. And to all of our delegates, hope you enjoy the rest of your Friday afternoon, and thank you ever so much for joining us.